Ji, and who, along with the discussants, will get about the session. And I think Mr. Ajay Ji has proposed a kind of organization of that session. And once that is done, we will have Dr. Sangeeta providing the summary remarks, and hopefully at the end, Dr. Sanjay Saha will provide to us the vote of thanks. So that is a brief review. And
good afternoon, everybody. I was having difficulty joining Ajay Shankar ji. Everybody has Sangeeta, Harshji, Sangi Saab, everybody. Hello to all of you. Dr. Mehrotra. I'm sorry I had difficulty joining on the link, but now I'm there.
Wonderful. So shall we begin? I think we are good to start. Maybe so everybody's here. Great. Well, good evening.
Sir, give us 2 minutes. We will go live. Chetan, please let us know when to go live. And then, sir, we will begin at a count of 10.
Okay. I think we are all set. So you let us know.
Yes, sir. We are ready and we will go live after 10 seconds.
Okay. Thank you very much, all the panelists, Sangeeta, everybody here. Thanks
to see you, Harsh. Hi.
Yeah, really appreciate it.
Okay. Well, good evening, everyone. Member Board of Management, JKLU, Shri Harshpati Singhania, Honorable Vice Chancellor, JKLU, Dr. Dheeraj Sanghi, esteemed members of Federation of Indian Chambers of Commerce and Industry, and our esteemed chairperson and esteemed panelist today, Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group and former President, FICCI, Dr. Harsh Mahajan, Co-Chair, FICCI Health Services Committee and former President and Chief Radiologist, Mahajan Imaging, Dr. B.K. Rao, Institute of Critical Care Medicine, Sir Gangaram Hospital, Mr. Sanjay Mitra, former Chief Secretary, Government of West Bengal, Professor Santosh Mehrotra, Visiting Professor, Center for Development at University of Bath, Mr. Ajay Shankar, Chairperson and Distinguished Fellow of Center for Policy Studies, JKLU, Dr. Sanjay Saha, Chief Economist, JK Group and Fellow of Center of Policy Studies, and Professor Afreen Faridi, JK Lakshmipati University, and dear attendees. I, Ashish Gupta, Pro-Vice Chancellor, JKLU, and member of the Advisory Board at the Center for Policy Studies, I'm really privileged to welcome you all to this exciting session on behalf of FICCI and the Center for Policy Studies at JKLU. The fact that we had to meet virtually highlights the circumstances in which we all find ourselves due to the COVID pandemic. We all know that this has infected over 33 crore humans worldwide, has resulted in so many lost lives, people succumbing to the virus. And there can be no doubt that COVID pandemic has put an even greater focus on the health of the healthcare system. It is to take stock and prepare for the future that the Center for Policy Studies sought to undertake an in-depth analysis of the healthcare situation in India and propose a way forward for stakeholders to work together in addressing this pressing issue under the leadership of Mr. Ajay Shankar, our chairperson, who earlier served as Secretary to the Government of India and headed DIPP and several institutions such as National Productivity Council and Quality Council of India. The virtual roundtable on a roadmap for universal healthcare presented by FICCI and JK Lakshmipati University to discuss the findings and implications is a step in that direction. And it brings together some of the most eminent policy framers, healthcare providers, thought leaders, corporate experts, and academics in the country. Without taking any more time, I hand over the session now to Shri Harshpati Singhania, Honorable Member, Board of Management, JKLU, for his welcome address. Mr. Singhania.
Thank you, Ashishji. Pleasure to be here at this webinar and on healthcare based on a paper that has been put out by the Center of Policy Studies at JKLU. First of all, I'd like to express my sincere thanks to all the panelists who have gathered here and who readily agreed to participate in this and to my dear friend Sangeeta, who within 15 seconds agreed to chair the session. Thank you, Sangeeta. Thank you, Dr. Malhotra, Dr. Mahajan, Rao Saab, and Mr. Sanjay Mitra, whom I know well. Ajay Shankarji, thank you for doing this, and your work is very important, particularly at a time when, as Ashish said, all of us are seeing the impact of COVID, or I frankly have seen this in the last couple of years, and what healthcare criticality is in not just in our well-being, but in livelihoods and the nation's progress. But before we get into the seminar, allow me a minute to talk a little bit about JKLU. So we from the JK organization, as part of our philanthropy approach, decided about a decade ago to establish JK Lakshmipat University. It is named after my late grandfather, Lala Lakshmipat Singhania, who of course was an entrepreneur, a pioneer, a visionary, but he was very interested in education, including that for women in his personal life as well as in his public life. He believed that education was the key to the development of our nation and therefore took keen interest in it. And therefore it is very befitting that the university be named after him. The university today comprises of three broad institutes: that of engineering, that of management, and the more recent one in the last few years is the School of Design, which already in a short journey is being recognized as one of the most innovative and most recognized institutes of designs in the country. The university has tie-ups with several other institutes and universities overseas, including several in the United States, as well as in the UK. And therefore, students have an opportunity to go and study there as well. We have some joint programs where they do an initial work at JK Lakshmipat University at Jaipur, and then they go on to finish their studies and get a degree from that foreign institute. They've also had opportunities to study at IIT. So we have several tie-ups of that nature. Also, apart from having centers of excellence, Niti Aayog approved the setting up of an Atal Incubation Center at this university. And within a short span, it is heartening that it is home today to more than 30 startups. If we were doing this physically, you would have had the opportunity of visiting the university and its facilities, but we hope to get hold of you at some other later date. The Center of Policy Studies was launched as an independent think tank at JKLU in February 2020 to promote dialogue, conduct and publish research, and develop actionable ideas on critical issues to inform policy making in India. It is led by Ajay Shankarji as a chairperson and as a distinguished fellow, who also serves on the board of governors of JK Lakshmipat University. And it also has the benefit of having senior academics from University of Massachusetts Amherst on its advisory board. The center gives an opportunity to contribute at a larger level with the involvement of leaders and thinkers along with this team. Today's discussion is, as I mentioned, regarding healthcare. I don't need to talk more about healthcare. We are all acutely aware of it. But suffice it to say that this is an underserved area in our country, and it needs much more impetus and attention and outlay, if I may say, both from the government as well as from the private sector. We are hoping, and I'm sure all of you, as well as Sangeeta, particularly because of her involvement with FICCI and Dr. Mahajan, that the upcoming union budget will have much greater outlays on the healthcare sector. So the Center of Policy Studies have made a policy paper on a roadmap for universal healthcare. And it touches on 4 core themes. The hospital development. Second is full, holistic, free public health care. The third is modernization and digital health technology. And the fourth is reform the private healthcare and insurance. Now, these are all vital things. And Ajay Shankarji himself will be talking about this after I speak, introducing the topic and talking about the research findings. We only hope that this becomes, and with your inputs from all the panel discussions, and your direction and your ideas will pave the way for us helping our policymakers and thinkers evolve a stronger and a more robust healthcare sector in our country. And I'm deeply indebted to each one of you for helping make this happen. After all, it is the lifeline, and no pun intended, of our nation. Thank you very much, ladies and gentlemen. And now I think I will hand over the floor to our chairperson, Dr. Sangeeta Reddy. Sangeeta, all yours.
Good evening and namaste. Harshpati, my dear friend and always an inspiration, let me begin by congratulating you, not only for following in the legacy of your illustrious family, but finding that tremendous link between education, commerce, and the betterment of the nation. So congratulations to you, the university, and all of you who are truly making the world a better place through education. It is my pleasure and my privilege to be here. I want to especially thank Mr. Ajay Shankar for the time, effort, involvement, and depth of what he has done with his paper. I went through it very briefly because I received it only today, but I do appreciate the fact, Mr. Shankar, that it is direct and prescriptive in an environment where we have no time. And therefore, it will be a pleasure to deliberate and hear the views of the illustrious people who are joining us here today. And so Dr. B.K. Rao, Mr. Sanjay Mitra, Dr. Santosh Mehrotra, and of course, my good friend and FICCI co-chair, Dr. Harsh Mahajan, and all members of the University of FICCI who are here with us today. While this may seem like a closed panel, it is indeed an open and very important dialogue for the country. All of us together, I believe, are cognizant of the fact of the complexity of the healthcare, of the different dimensions. People talk of affordability, accessibility, quality, cost, and we are equally, I think everybody, every member of public is truly amazed by one thing which is quite so obvious, that we have continued to underspend and underfocus on healthcare. And yet at the same time, where the private sector has put in so much, I think it is unorganized and underappreciated. So there is much to be done. I think it's important for us to be educated on the fact that on one hand, we are all very aware of the pandemic, but the underlying epidemic of non-communicable disease, which is truly the underlying tsunami, and also the resultant of this pandemic, the infodemic, and the fact that in an educated environment, information and the right information is truly the first step towards saving lives. Equally, I think we are hopeful about the role that science and technology will play in enabling us, possibly, as we look at the calculations for number of beds required and look at the fact that I think the estimate is we will need at least 2.4 lakh crores or 6 lakh crores for the required number of beds, depending on the estimate taken from the paper. Is it possible for science and technology to play a proactive role in earlier diagnosis? Can we find our cancers at stage 1 as an outpatient procedure and therefore have less hospitalization? Can we obviate the need for more beds or at least minimize the need for beds? We definitely need more beds, but can we change the paradigms using science and technology? And of this, I'm truly hopeful. I believe that collectively, all of us are compelled to action. And that compulsion comes from the fact that every minute we waste, every day we don't do proactive movement towards a positive policy and an equitable outreach of healthcare is a day that we are denying someone care, and sometimes, very sadly, we are denying a family of their loved ones. So we are compelled to action. In the same breath, I think we are inspired. We are inspired by the great work done by doctors, by nurses, by healthcare workers. And in this pandemic, I think sanitary workers, police people, everybody came together, housing communities, and how they organize themselves. So I think truly we are inspired that as a country, we can come together towards a positive cause if appropriately directed. And finally, I believe we are together in the belief that we need a better healthcare system. And today, through education and knowledge, Harshpati ji and JKLU, you have taken this positive step, and it's indeed my pleasure to be a part of it. I'm not going to go into details of my thought process around the needs and the compulsions, because today my role is merely as someone to help coordinate the conversation, to help present the thoughts of Mr. Ajay Shankar and then hear the views of the other participants. However, I will say one thing, and that is that India is capable of very advanced healthcare. And 40 years ago, when we established Apollo, my father established Apollo, he had one single vision or mission, and that was to bring healthcare, world-class healthcare, within the reach of every individual, and to stay committed to education and research and the best of clinical care for the benefit of humanity. And I think that remains the ideology that many of us in the healthcare sector practice. And it is because of this that patients from all over the world are ready to come to India for treatment, that many people who needed to go abroad, that need has been obviated. So how can we in the same breath channelize this positive capability of the Indian healthcare system and juxtaposition it, intersperse it with the need for advanced primary healthcare, the proactive need for preventive healthcare, and a need for universal access and insurance. Put this together with the data and the capability to evolve new solutions using AI and other methodologies to enhance the level of care. So the task in front of us is definitely important, is dynamic, but I think it is something we're capable of doing. With these words, let me please hand over to Dr. Ajay Shankar, Mr. Ajay Shankar, and we look forward to hearing more about the paper which he has put forth. Mr. Ajay Shankar, over to you.
Thank you. The paper recognizes that we have a globally competitive capacity as far as provision of healthcare is concerned. Sangatyaji, your institution represents that, and so do others. So it's a great success story. We also have a globally competitive pharmaceutical industry. So we have very, very two strong achievements with us. World-class ability to provide care at costs which are a fraction of US costs. We also have a pharmaceutical industry which produces materials at a fraction of the cost and sells it at a fraction of US costs in India. So those are two very great strengths. But we also have the paradoxes in the health sector as they are in other sectors. You pointed out one of them, that public spending and importance to healthcare is far lower than it should be. The healthcare is a state subject, and there is great variation across states. And the weaker states really need a lot of attention. And within weaker states, the weaker districts have a great problem. Then we also have a huge problem that we have a very large section of our population, which we describe as weaker sections of society, and who are today getting state support in terms of employment through NREGA or through, the Food Security Act. But complete healthcare is not there for them. And if something happens, they're really driven into extreme penury. So what the paper has tried to do is to look at the whole issue in all its diversity and complexity and come out with very specific ideas of what can and should be attempted. And the idea is to generate discussion around each of the ideas or thoughts or suggestions that have been put in. But the goal that we have set in the paper is that in 5 to 7 years, we should have universal health care from birth to death or from cradle to grave, which is comparable to middle income countries. I think as a country, we can achieve it, we can provide it. And this would also require the state certainly improving and enhancing its commitment to the healthcare sector and putting in far more resources than it has done. So we've said that 1% extra share of GDP would go into the healthcare sector in the next couple of years, and we should try and take it certainly above 3% over the next 5-6 years. And that combined with all the benefits of technology that Sangeeta ji referred, and if we can adopt it very quickly, then we should be possible to achieve this goal. So that's the broad, canvas in which we have spelled out our ideas. Now, the discussion, as was mentioned earlier, would be around 4 broad themes. So the first one is on making good the shortfall in capacity of healthcare. I mean, the paper we've called it hospital, but when I was reading it again today, we should have the healthcare capacity, where hospital beds are a critical component, but the paramedical staff, the medical staff, the testing facilities, all are part of that requirement. And what we have said is that in each district, we should identify the gap. Because I think the present practice that people from remote villages come all the way to Delhi should come down, and they should come to Delhi when they really need to come to Delhi, but the local district facilities should be able to take care of most needs. So we have recommended that we should have a national program for creating this capacity. And for that capacity, the figure of 5 lakh crores was mentioned. That's what we think we need to get 1.5 beds per 1,000, which is still pretty low because many other countries have 3 to 6. But assuming that we use all the technology that is there and use it very productively, the need for hospital beds globally is coming down, and therefore, hopefully, we should be able to manage with 1.5 or maybe a little less. What we have suggested is that in the infrastructure pipeline of 100 lakh crores, this must get the highest priority, and then 5 lakh crores is not too much. And the state governments must come in with the commitment to recruit staff in time, buy equipment in time, and make the capacities functional as soon as the physical infrastructure is in place. And we have come up with one somewhat different idea, that we adopt the practice of the armed forces, which is recruit people when they're very young, fully fund the cost of their education, and take a commitment that you'll work with us in these remote locations for at least 5-7 years. Thereafter, you can be free and go and seek your good fortune in India or the rest of the world, or you pay back sufficiently for the investment made in you and your education. Because we have a problem that people are reluctant to go and serve in backward areas in all sectors. And therefore, the suggestion implicit in what we've argued is that you recruit people from that area on the basis of talent, put them through the education, let them go and serve there. So that's the somewhat different idea that is there, but an investment in education and recruitment in parallel with the commencement of physical construction. So that's the recommendation in this part. And I think with this, I would now leave it to the panelists for discussing it. And Sangeeta ji, would you like to request Dr. Rao to begin the discussion, or?
That's perfect. So just for everybody's, once again to reiterate, there are 4 main themes. There is hospital and healthcare development. There's the full holistic free public healthcare. There's modernization and digital healthcare, and there's reform in private healthcare and insurance. The format that we will follow is Mr. Ajay Shankar will give opening remarks, and then I will request panelists in differing orders so that it's not the same person last all the time. And hopefully we'll start with the person with the significant deeper work in that particular area to comment on this. So we'll start with this first round of the 4 rounds that we will be doing, which is your comments on hospital and healthcare infrastructure development. So may I request Dr. B.K. Rao?
Am I audible now?
Yes, you are. Thank you.
Okay. Good evening. Good evening, Sunita ji. Mr. Ajay, can we make this interactive rather than me giving a comment?
Please do, please.
So, the 4 ideas that you have given, they are great ideation as far as that concept is concerned, but they will all have different levels of complexities in terms of the implementation, in terms of the feasibility, and they are at different level of implementation even now. So, they will differ in that background as such. But what I see here, there are 728 districts in India. And I presume that at a district level, you will be looking at a hospital which is 200 bedded, 250 bedded. That's the max you will be looking at. So that gives you around 1.5 lakh beds. And we are short by 13 lakh beds. And I'm not going into the detail of this figure of 5 lakhs, but the fact is, in this, are we presuming that the state governments don't have the funds, and so the center needs to make the hospitals for them? Because this has been a bone of contention between the center and the states, because they just can't hand over the the building and everything to the state. There will be riders on that. So there will be complexities in that. And secondly is, at a district level, getting human resource is a big challenge. So when we leave it to the state has limited access to healthcare resource in terms of the manpower, because not every hospital, every state has got medical colleges. So we know that the concentration of medical colleges is more down south and in certain parts of central India. So every state will not have access to that kind of specialized human resource. So how do you see the practicality of this proposal?
I'll respond, but maybe let the other panelists come in, because this is a very, very radical idea and a challenging idea. But I felt, and we felt, that unless we address the gap at each district, the huge disparities that exist today will persist for another 10, 15, 20 years.
Mr. Sanjay Mitra, may I request your comment, please?
Thank you. This is, I partly agree with Dr. Rao. I would like to comment, let me just, I really was struck by what Dr. Reddy said, that we should not be daunted by the huge number of beds, and maybe technology can be used to maybe somewhat control that number, because that number is out of control at this point of time. And every 3 beds will require a nurse. I'm forgetting about the doctor. Doctor is a bigger investment. That means we'll probably require 50, 60 lakh nurses 5 years from now. We generate not more than 2 lakh or 3 lakh nurses here, including A&M and GNM. I'm not talking about BSc nurses, which is the kind of people that Dr. Reddy employs. So it's going to take a very long time to get hold of the manpower. I think finally, rather than money, Dr. Rao, money is there. States may not have money. Center probably has money because of the massive amount of tax it's got from petrol and diesel. States have also got it. But states are under increased fiscal pressure because of COVID. And whatever it may be, resources can be found. But I think our main problem will be personnel. I don't know how to solve that. Because nursing care is the final cutting edge. Number of nurses you can provide, and that my numbers say that is very hard to do. Having said that, I would like to go back to what Dr. Reddy said. COVID has actually changed the health sector. It is very different from what the health sector, which I headed 10 years ago as health secretary and then as chief secretary of the state. For example, I could never imagine that somebody from the municipal corporation will call me and ask me about my health. That is a huge thing. I could never imagine. None of us in this room can imagine that 10 years ago, 2 years ago, somebody will call me on a regular basis and say, "Aapko bukhar hua hai kya?" So are you self-isolating? So clearly we have capacity, and this has been possible through digital tracking. So maybe is it possible on a long-term basis to convert this COVID thing into a regular referral system where, I am linked in the district, I am linked to some doctor in the public health system whom I can call using my phone and, get in touch with that person. Other than this, sir, using our traditional method of beds, nurses and doctors, we're going to run into a big problem in order to actualize this idea in a given time frame, because we simply don't have the manpower. Money can be found. Whether a cess is practical, Santosh Mehrotra can tell us whether we can impose yet another cess and what happens to the sharing of the cess proceeds, what happens to the hospital, what happens to the building. We can talk about all that. But manpower constraint will be the main thing. So maybe we can all think about how we can re-engineer the setup we have created under COVID, which seems to reach out to every person. I mean, I'm actually totally surprised. I mean, I got calls that, how are you? What do you want us to do, etc., etc. So this is my comment, that the ideas are great, but we're going to run up against manpower constraints, and maybe we can use digitalization to some extent and maybe relax. It may not be a nice thing for the doctors on the panel to hear, but maybe relax some of the criteria for medical colleges in terms of, the kind of infrastructure you need, the kind of beds you need, the number of specialist trainers you need, that kind of thing. Maybe relax the requirements so that we can generate more medical doctors and maybe more nurses. Thank you.
Thank you so much, Mr. Mitra. Very deep and insightful comments, truly. Dr. Mehrotra, over to you, please.
Thank you very much. Thank you for inviting me. I read the paper by Mr. Ajay Shankar with great care, as I always read everything that he writes with great care. He's an extremely wise man with enormous wisdom and ground reality evidence to back what he says. But let me say a few things. Firstly, on hospital beds, the current situation is that in the country, we have 0.5 bed per 1,000 population. The WHO recommends 5. So we are short by 90%. We're only 10% of where WHO. And to give you a feel, so Shankar Sahab's recommendation of 1.5 beds per 1,000 is just not ambitious enough, with all due respect. I mean, I'll exemplify this by giving you a sense of what the situation in UP is. Because 4 years ago, the Yogi government had actually asked me to help them create a national state health policy, and I did. And unfortunately, the UP state government never even made it public. But you need to appreciate what the scale of the shortages is in sub-centers and PHCs and CHCs. So UP requires 31,000 sub-centers. It has 20,000. That means the shortfall is 34%. PHCs required is 5,000. We have 3,500. Again, shortfall is 33%. The CHCs required is about 1,300. We've got 770. That means the shortfall is 40%. So there is no getting away from raising the public expenditure to GDP ratio, and both states and center will have to bear this burden. I'll come to Dr. Rao's point in a minute. Let's just remind ourselves that this government was the one which committed itself in a national health policy in 2017, January, to reaching 2.5% of GDP for health expenditure for the government by 2025. One would have thought that there would be some progress towards that. Unfortunately, there has been none since 2017 till now. We didn't even get to see this in last year's budget, if you exclude the COVID vaccine expenditure. Let me turn to Dr. Rao's point about states. Do they really not have the funds? Well, I think Mr. Sanjay Mitra was absolutely right that they have been the ones which have been at the receiving end of the increased expenditures, particularly of COVID management generally. And while health is a state subject, the tragedy is as follows, that if you look at overall health expenditure in the country, state and center taken together, 1/3 of it comes from center, 2/3 of it is by the state, but of what the state spends, 80 to 90% goes on spending on salaries. 80 to 90% goes on salaries and the remainder goes on operation and maintenance. So where is the leeway to increase physical capital investment? And I've already talked about the infrastructure shortage. We haven't even begun talking about the human resources. So the implication is, to reinforce the point that Mr. Mitra made, that the funds have to be found. And the Finance Commission, the 15th Finance Commission, just chaired by N.K. Singh ji, strongly recommended that the government needs to do something about it. Now, where are the funds going to come from? Clearly, a cess is not a good idea. We've already seen cesses being applied by the central government on diesel and petrol, which are retained by the center. And the states resent that deeply. And so therefore, there is just no getting away from it, that the government may have to consider both things, or at least one of two things. One, the government has no choice left but to begin to put surcharges on the super rich, on their A, wealth, and B, on their on corporate incomes. Despite the fact that, because we reduced the corporate tax rate, corporate tax temporarily, at least for 2 or 3 years, to deal with the pandemic and to deal with the shortages, that needs to happen. So one is tax. The other, of course, is the government goes in for health bonds. In other words, it borrows specifically for the purposes of investing in the health system. Let me stop there. I mean, I've spoken of sort of macro things here, but many other things will come up as we move along. Thank you.
May I just make 2 brief comments before we move on to the next thing? So with your permission, I'll respond very briefly to points made and then come to the next theme. We had debated and chosen the number 1.5 beds, recognizing that this is far below what many neighbors have achieved. But we also recognize that there is only so much we can do in 5 years. So we felt 5 lakh crores in 100 lakh crore infrastructure pipeline over 5 years is not unrealistic. And it's a fair balance, because the states have to pick up the entire tab on the operation and maintenance costs. It's a one-time central support. And the central government has been funding things far more generously in so many other areas. To just give you one example, I mean, farmers are in distress and they're center of attention, but it's 72,000 crores a year which we give them every year as free grants. 80,000 crores a year is the subsidy which goes for electricity for irrigation. And here we are asking for healthcare barely just 1 lakh crore a year for 5 years. So I think I wanted to drive home the point. The second point was made about manpower resources. Now, India is full of young people dying to get jobs. So I don't see why somebody in Barhampur or Bhagalpur cannot be recruited out of school, trained and made good enough to be a paramedical staff personnel in that district hospital or primary health center 4 or 5 years down the road. So that's the approach we are recommending, that pick up young people and train them. And young Indians are eminently trainable. I will not talk of the current day and age, just go to India Gate, a memorial to 1 million soldiers who fought as well as the Germans with a 3 to 6 months training in 1914. So that's the potential we have. So these 2 responses to the points made. Let me move on to the next one, and which is the very important one, which is that for the weaker sections in the poorer states, life is really very harsh if you get a health problem. In the southern states, the public healthcare system is admired, and I don't know them well enough, but I think that they're quite exemplary, and it's reflected in the health parameters of a state like Kerala. So we need to bring up UP, Bihar, etc. to these levels, and the only way it can happen is if there is a policy decision, A, to cut expenditure wherever else it may be required. After all, when somebody falls in the family, we cut expenses everywhere else and find money to take care of the health. So as a country and a society, we need to do that and provide holistic, free health care from birth to death. Because I think it's now accepted world over that and what we learned in school, a stitch in time saves 9. So preventive healthcare saves enormous healthcare costs later. Sangeeta ji, you rightly referred to the fact that you diagnose cancer at the first stage. Now we have a system that for ordinary people, preventive healthcare, at least in the northern states, doesn't exist. A routine medical check, a routine assessment of what needs to be done, etc., etc. So that should be the policy goal. Then you create the capacities to deal with it. And you also move to a situation where you move away from the present paradigm, which is health insurance for a treatment, to a total healthcare system, which covers essential medicines, not frivolous medicines, as well as treatment. And the preventive healthcare has 2 dimensions, both of which are completely neglected. One is the healthcare from externalities. Now, if Delhi air pollution levels are 10 times what WHO recommends, we have a health emergency and the individual can do nothing about it except staying indoors and having air purifiers. So the state has to move and act there, and it may cost money, but that money is well worth it. Similarly, Gorakhpur, you have this sort of whatever awful thing which takes away so many children every now and then. It's a problem of drainage and sanitation. Now, why can't we find the money to set it right? The next one is personal lifestyle. Now, I was ages ago very impressed by a Japanese colleague who said that every year he needs to have a medical checkup, and if his weight goes up by even 1 kilo, he's in difficulty. Now, here we have a diabetes epidemic, and yet we are unable to communicate effectively and get lifestyle changes. We have anemia, which is widespread amongst young girls. We are unable to communicate to them and get them to eat the right local foods and overcome their anemia, and also to get their blood tested. So we are arguing in this paper that take a holistic approach, set yourself a 5-7 year time frame for setting it right, state by state, district by district, and you have to find the resources to do it. And there's this thing that we have a fiscal deficit or a fiscal stress just doesn't make sense, because I can easily say, okay, knock off this item or this item of the public expenditure, because you do it if your own family was involved. So I will leave it at that, and again request Sangeeta ji to now ask.
Thank you, Mr. Shankar. I think on the points that you've raised of a holistic approach, focusing on primary care, prevention, there can be no debate that this is critical. It is very important and has to be universally available. I just want to add, and I think this is a well-accepted fact. I'm not going to go into the details, but I will call attention to a paper which I will send you on total health, where for the last 9 years, we have managed the health of a community of about 70,000 people from birth through life, all social determinants of care, from sanitation, nutrition, etc., are first focused on clean drinking water, and then layer by layer, an insurance, primary preventive screening, access to the government hospital, communication. So there is no doubt about the approach of a holistic system. I think one of the other things which came up earlier, which I want to call out because they're all interconnected, is number one, the need for innovation, the need to re-engineer some aspects of the health system, because very often the public are left to fend for themselves without having a pathway or care. So the points which were made by Mr. Mitra in terms of have one person to help you navigate, have somebody that you can call upon. The important point also of this continuum of care, because every step of the care system has correlation to the other. And if you do primary and preventive right, you're going to reduce the amount of advanced care that you need. So I think the debate we need to bring forth, and I'd request speakers to talk about of how are we going to do it. And that therein lies the key. The fact all of us are 100% in alignment on the need for holistic, universal, primary healthcare and continuum of care. So I'm going to start with Dr. Mahajan. He did not have a chance to speak at the last round of debate. So Dr. Mahajan, would you like to take a cut at this, please?
Yeah, thank you very much, Sangeeta. Just a thought about what Dr. Mehrotra summed up at the end, that, there is no money. As he showed, it has to be taken from somewhere else and be fed into the healthcare system. And if after COVID, our governments are not able to do that, then it's certainly going to be a problem, whether it's through a health cess or some other means, or I don't want to take money away from someone else and use it here, but some jugglery would definitely need to be done. And even though the focus ultimately, would need to be on hospital beds, and they need to be there in every district, there is no denying that. But if we were to channelize our energies also, as you said, using new innovative methods on preventive and primary healthcare, and also providing access to far-flung areas through telemedicine, which has worked so very well in COVID times. I, as a physician, I can tell you, I mean, as a radiologist, we've been using teleradiology for a long time. But most of my physician colleagues, when told that they could do this, they would say, no, it's just not possible. So that there was so much reluctance on part of healthcare professionals to use telemedicine. What to say about the patient who did want hand on the shoulder? But I think both communities have now come to agree and believe that telehealth is possible. Telemedicine works. And this was during, if you saw the second wave of COVID, where it was serious disease and things worked. So if it can work for serious disease, definitely it can work for, day-to-day ailments for which patients have to rush to hospitals just because primary care in their geographical area is lacking. And so telehealth, I think, has to play a major role. And like you very rightly said, it is part of a whole system where this could be one of the first pieces. And then comes, home health. Home health, again, is something, because everything doesn't need to be treated within a hospital, which is what is happening now. So maybe we have 0.5 beds per 1,000 population right now. Maybe Mr. Shankar is right that 1.5 or 2 may be all that may be necessary if we can look at the other pieces. We have an aging population, so elderly care, and that again can be delivered very nicely, remotely. So these are areas. And then we work in the field of artificial intelligence, and artificial intelligence to some extent in the years to come. Of course, these are still early days. In the years to come, may be able to provide some kind of assistance to healthcare professionals, be they doctors, be they nurses who are trained as a kind of replacement for doctors in areas where doctors cannot reach. There, with artificial intelligence algorithms, it may be possible to provide health, remotely. So I think the solution will lie in looking at innovative ways of doing it, and ultimately, even these will cost money. Somehow, what I've seen in my 30 years that I've been, in the practice of radiology, having installed the MRI in 1991, that somehow the feeling, even when I do a free scan, somehow the feeling amongst public health officials is that I'm making a profit. And this feeling somehow, this distrust, has to be bridged, because 70% of healthcare in this country is still in private hands. And there is no way the government can leapfrog and provide even 50% in the short term. So we have to work hand in hand, and somehow this distrust has to be bridged if we are able to move forward towards universal healthcare, which is a very laudable goal. And one final thought. Somehow when we talk of allopathy, we forget that we have Indian systems of medicine as well, which are performing, especially in tier 2, tier 3 rural areas. We also need to somehow develop a policy, a system, how to bring the two systems together. Maybe the primary healthcare centers can be manned by Ayush doctors, and when the need arises, it can be escalated. So this is something, again, we are actually not utilizing very efficiently those doctors that we have who've studied indigenous systems of medicine, and they, I'm sure, have their own role to play in universal healthcare. Thank you very much.
Thank you, Dr. Mahajan. I think a wealth of knowledge showed up, and you very seamlessly moved to our next topic, which is the digital health technologies and modernization. Just considering the time, Mr. Shankar, I will request you to move directly into the digital technologies. And we will stay brief because I think we have only 20 minutes left. So over to you, Mr. Shankar, again. You're on mute.
Mr. On Shankar. Modernization, I have nothing much to add to what has already been said. I think healthcare is at an inflection point globally. And within India, I think we've taken the leap because of the necessity of handling COVID. So telemedicine is now a reality in the more privileged parts of India. And medical practitioners are seeing the advantage of that. They're adjusting to it. So if we use the entire power of telemedicine, I mean, to take an extreme, you can run call centers where round the clock somebody in a village can get through to somebody anywhere in the world, not even the district headquarters. But if all that is digitally linked, then you can cut down the cost of care dramatically. And there are two other aspects which we pointed out in the paper, which also I think I'd like to flag, is that there is a need for certain standard operating procedures and standard guidelines for both the medical healthcare providers as well as the consumers of healthcare. So I was hit by the need for this very dramatically, because in India, anything happens, my system gives me an antibiotic straight away, 3 days, 5 days. And I had gone to the UK with my granddaughter in the NHS system, and the only thing the TV screen was displaying is don't ask for antibiotics, don't take it. And so there is so much of need for standard operating procedures. And in COVID, again, we've read so many reports of people going desperate, paying fortunes for certain drugs, which turned out at the end of it had no real medical value. So and even doctors need that kind of guidance, because after all, they're very busy, harassed people. So
since this is also a FICCI platform, I'm happy to share with all of you that as long ago as 7 years ago, FICCI gave to the Health Ministry standard treatment guidelines, which were formulated by multiple expert groups. So there is no doubt that we need that in addition with technology. I just want to add one point, that telemedicine is often thought of as a doctor-to-patient connect, but it's also a very powerful doctor-to-doctor connect. So to enhance the capability of rural healthcare, the fresh doctors, the junior doctors, those who have been educated and asked to take positions, as well as the ASHA workers who can be connected. There are many usages of this connected technology area. So I think what we will do is jump directly into the next most important realm, which is the reform of the private healthcare and insurance. And here, Mr. Shankar, I would request you to also dwell a minute on the very important point that Dr. Mahajan raised, which is the trust factor, and using the private health sector together with the government in an integrated framework, because survey on survey is showing that the preference of public is for the private sector. There are unfortunate scenarios of overcharging, which seem to tar the whole community with a negative brush. However, there is a power and a capability in finding a way to solve this system so that we can work in tandem. I think in the affordability and accessibility area, insurance has a very powerful role to play. But the third A is the A of accountability. And here I think accountability of all clinicians for the services they offer, but equally accountability for the structures which are built and the money which is built and the throughput and the productivity which is often seen in the public sector is also to be asked and questioned in an environment of scarcity. Can we afford to do that, or is there a better way to access the productivity of the private sector in a structured environment to deliver the kind of care which is required, enabling greater optimization and utilization of resources? So with this, back to you, Mr. Shankar, and then to all the eminent panelists, I will be requesting each one of you to comment on this as well as any other almost like concluding remarks, because we have been requested to close in 15 minutes.
On the private healthcare and insurance, we have recognized that it's a fairly competitive situation and we have extraordinarily good capacities. So our recommendation is a one which is relatively speaking simple, but which is that if we get the insurance companies to give full coverage rather than procedural coverage and from birth to death, and they are able to then tie up with private healthcare providers from tertiary care to primary care, then you create a virtuous cycle where quality healthcare is given competitively and costs are a material consideration. So this is the core of the recommendation on reform of for the private healthcare and insurance, because the US system and our system is imitating that, is that we give full reimbursement. So the service provider has no commercial incentive to control costs, and the insurer has no commercial incentive to control costs, because the two are working on full reimbursement basis. So if we get the two together to give full coverage, and the consumer chooses on the basis of the premium, which is premium not for a procedure when he needs it, but full lifelong care, and the service providers and the insurance companies, the market will be forming consortia over a period of time. That's our core recommendation. And in terms of the private sector and public sector, we have said that partnerships and outsourcing has worked well. There are issues on how to arrive at mutually satisfactory relationships, and also recognizing that the private sector doesn't get money out of the printing press, they have to earn it. So that's a problem across sectors in India. But it's working well in some states. It needs to work more, because certainly it makes good sense for the state to see that healthcare is provided at the least cost to everybody, and to the extent they can get more cost-effective services from the private sector, they need to pursue it. But if in some remote parts the private sector is not there, then there is no option but for the state to create its own capacities and have the digital connection. So with these things, I think I've ended up all that I have said. Now the floor is open to all the panelists. You can request them to make their remarks covering all that is they want to say now.
Yes, I think I will request each one of you. Dr. Santosh Mehrotra, would you like to go first, please?
Thank you, Dr. Reddy. I'm going to pick up on your point about transparency and accountability in a minute of the private sector. But let's just remind ourselves that only 9% of our total employment or total workforce is formal. And only they have seriously regular jobs so that they could access private insurance. So let us not pretend that suddenly, the share of formal workers in our whole economy is going to increase overnight. So we've got to worry about 91% of our workforce, which is informal, and they need a functional public health system, something which we have been talking about. Point one. Point two, the trust in the private sector is great precisely because the government doesn't spend enough and has not made a public health system functional, which is the reason we are in a situation that 74 years after independence, out-of-pocket expenditure still accounts for 63% of total health expenditures in our country. The remainder is accounted for by government expenditures. In this context, there is no choice but to increase public spending. In the absence of that, this OOP is not going to decline, and out-of-pocket expenses is the second most important cause of families falling into poverty after dowry. My second point is about the transparency and accountability point that Dr. Reddy rightly made. Clinical establishment acts exist in our country only in 11 states. We are a country, I think, of 29 states and 7 or 8 union territories. Every state needs to have a Clinical Establishments Act, which ensures that costs, a cost of a procedure, cost of a hospitalization, cost of ICU, cost of respirator, etc., needs to be made public. It should be available on a blackboard outside the hospital. And once that is made clear, then people will know they might be expected to end up paying. In which case, there might be, we are hoping that if every state had a Clinical Establishment Act, then at least there'd be some basis for transparency and accountability. My final point is about Ayushman Bharat, which is just a slight improvement upon the RSBY, which had existed earlier. And I think to reinforce the point that Ajay Shankarji made, I think it's absolutely critical that hospitalization alone cannot cover all the needs. In fact, most out-of-pocket expenditure is accounted for by 3 things: drugs and medicines, consultation, and diagnostics. And that exceeds hospitalization costs. In the country, the share of out-of-pocket expenditure on health, which is accounted for by these 3 things, is greater than that of hospitalization. And this is not what is covered. This is a serious problem. And forgive me, no insurance will actually cover these things. We are not United States, and how we are going to ensure cost containment, the US has not managed to do so. The US spends 15% of GDP, and this is my last point, on health, of which half is spent by the state and half is spent by the private sector. But no rich country, no OECD country spends more than 7% or 8% of GDP. Most of it is accounted for by state expenditure. Thank you very much.
Very powerfully put, and very important points. Before we move on, I just want to share one very important, I believe, angle or perspective. In our pursuit of universal health coverage, so starting with RSBY, Ayushman Bharat, Pradhan Mantri scheme, I think the need to have a tiered structure for payment, because it's the middle class which is now being squeezed out of any kind of coverage. The upper, the rich is capable of buying private insurance, the lower class is now covered, the middle class is uncovered. So a methodology for a much smaller premium payment, but covered under this universal health coverage scheme, is, I think, one of the most pressing needs of the country. In addition, an ability to cover outpatient or primary healthcare. In this one, I want to draw all your attention to almost at the beginning when health insurance was being debated in the country. We deposed in front of the parliamentary committee and said, if insurance is structured in general insurance, like a car or a house or a factory or a machine, then people will think of health in an annualized basis or like America per member per month. Whereas we need a long-term view of healthcare, like Dr. Ajay Shankar was saying. And towards this, India is one of the few countries where health insurance is also covered by life insurance. However, unfortunately, the life insurers are not creating long-term policies. So the policy structure framework enables life insurance companies to offer longer-term premiums, because if you want somebody to spend on a mammogram this year, it takes up 50% of the premium cost. But if they did that, they would avert the breast cancer next year and therefore a 3 lakh bill. Only someone with a long-term view can find a way to do that, of course, a humanistic view. So my request is for every educated person who's listening to this to please seek for longer-term insurance coverages, because the structure enables it. I'm very, passionate about this subject of prevention and long-term view on healthcare. So forgive me for taking up precious time. May I quickly call upon Dr. B.K. Rao to please share your views on private healthcare, insurance, and any other topic. Please treat this as your closing remarks.
Yeah, on the one where I didn't speak was the holistic free public health. My take is that we should look for the low-hanging fruits, because not every preventive healthcare is going to be achievable in a specific time. Secondly, modernization we have talked about. I want to talk about the public health, the private health insurance also. You see, healthcare is an imperfect science. Everybody must remember. I give the same treatment to 2 patients, one recovers, the other one doesn't. So it is not like a pure science. So is the market. Healthcare market is also imperfect. We are bringing perfection into an imperfect market without understanding the very basis of that market is imperfect. So that is where the insurance comes in. And we must understand that when it comes to the cost, the private sector has been beaten blue and black, that you do much. But I want people to understand what makes the cost. How is private sector responsible for the cost? There is everything that we buy from the market. We buy equipment from the market, we buy drugs from the market, and there are a lot of things the government can do which will bring down the cost. So the onus of bringing down the cost should not be the healthcare provider alone. It has to be shared by the government. Say, for example, it was talked about the antimicrobial resistance. We all know the cost of ICU care is huge when it comes to the high-end antibiotics, but is the private hospital responsible for that? No. That is because the chemist is going to dole it out to anybody without a prescription. You were right, Mr. Ajay, when you said that you can't get antibiotics in US or in UK, but you go to a chemist in India and ask him for any antibiotic you want without a prescription, you'll get it. So the ills are not exactly only at the doorstep of the private healthcare player. The ills are in the society. We don't give antibiotics, people want antibiotics. So a lot of things are there. So in conclusion, I'll say that this is a very complex thing, and only private healthcare should not be blamed for the cost of care.
Thank you, Dr. B.K. Rao. Very well spoken. Mr. Sanjay Mitra, may I please request you for your point of view?
Thank you, Dr. Reddy. On the trust issue, I think sometimes there is political grandstanding where you want to show that you've done so much for the public and these private hospitals are gouging you. Having said that, Dr. Mehrotra, maybe there is a good case for all opinion leaders to say that we have to implement the Clinical Establishment Act. I tried to implement it 10 years ago. There was a fierce pushback from the doctors. And just framing rules took up so much time. What happened finally in my state of West Bengal is that we set up a health commission under a retired judge, which seems to be doing a reasonable job. And, we need to set, which sets rates and things like that and penalizes hospitals if they overcharge. There has to be a transparent system. And I agree with Dr. Mehrotra that there has to be a rate chart somewhere in the building or on the website, somewhere there has to be, in order to, gain greater trust. I was very taken up by your remark regarding ASHA workers. ASHA workers are somehow, we've given them the lowest possible wages you can imagine, and we have asked them to do very onerous jobs. They have done tremendous job in COVID. They actually called every patient and wanted to find out how they're doing. So if you can do it for COVID, as I said in my opening remarks, we can do it the other way around also. We need to pay them more. Ayush doctors was another great thing that Dr. Mahajan said. Again, there is a pushback from the, there are many allopathic doctors here, the big pushback from the IMA on the question of Ayush. But we need to be realistic. There is no way a man from, a remote village can come to you. You have to have some intermediary. The worst case we could even have nurse practitioners. What is wrong with that? That is there all over the world. But somehow that also has not, seen the light of the day again because of pushback from the doctor. And the worst thing is quack doctors. I mean, let us not ignore the fact that India is full of quack doctors. And I don't know whether do we use them? Do we touch them? They're happily treating people, and they're treating people in a big way. So what I would like to submit, madam, is that this think tank in Lakshmipat maybe should look at all these issues. This is only the first attempt that they've made, and it has been a fantastic thing. Maybe all the issues that were raised today, if Mr. Ajay Shankar could find more time, and and his institute and Dr. Ashish Gupta could find some more time for this, and this would be a great thing if they explore these issues further and come up with recommendations for future discussion. Thank you, ma'am.
Thank you so much, Mr. Mishra. And I think we all completely agree that there's more to be done. And I believe we duly note that the human resources point and innovation around this has come up time and time again. Dr. Mahajan, please.
Thank you. I think so many excellent points have already been made. I will just say at the end that the private sector has been wanting cost-based reimbursement, especially as regards CGHS, as regards Ayushman Bharat. We've been talking to the functionaries who matter in the government and trying to tell them that make it cost-based and let it not be L1. How can care in a Apollo hospital compare with care in a small 20-bed hospital? But somehow we haven't been able to make them agree to this way. Second, while all the time we are asked as the private sector, what are your costs? The government has never, ever come back and said, these are our costs. Take a surgery, a prostate resection, or angioplasty, or just a simple typhoid being admitted in hospital. How much does it cost a government hospital to provide that service? Can we know those costs as well? We are willing to share our costs, and we've attempted to make templates based on which a transparent costing could be done. FICCI has actually done that work, presented it to the government, I think about 5 years ago, and nothing came of it. The Ayushman Bharat rates, were taken, it seems, out of thin air, and the CGHS rates remain the same as they were about 10 or 12 years ago, despite the inflation that has happened. So if we could actually do this, I'm sure a lot of trust would be generated on both sides to know the real costs. And then in conclusion, I think population health is the best system that one can have, but whether it will be possible, how it will be done, one doesn't really know. Thank you very much.
Thank you so much, Dr. Mahajan. So with this, I think we've been through a round of very eminent, truly enlightened views on multiple aspects. We thank Mr. Ajay Shankar for his very seminal work on an important subject. We will conclude today's session by agreeing on some points. And that is, number one, that we do need more allocation to healthcare. We definitely need a greater infrastructure and number of beds across the ecosystem, whether that ratio is 1.5 to 10,000 or different, but we need more beds. The criticality of primary healthcare, and it's not just having the primary healthcare centers, but having them manned, equipped, manned or women, but staffed, equipped, appropriate medicine, good operating protocol, and a good linkage to the next level of care using telemedicine as well as physical transport systems and the latest standard treatment guidelines with adequate precautions taken on inappropriate use of medicines, as the very important point which was made by Dr. Rao. Moving on, I think all of us are in acceptance of the fact that technology, science, and research are critical. It needs funding, it needs innovation, it needs cooperation and collaboration. On the insurance point, universal health access, a longer-term view on insurance, an integration of insurance, a focus on low-hanging fruits, and a seeking of somehow finding a methodology or a solution for the missing middle. I think the one big point which came up across, and my big request to the university, is that there is a further work and research done on human resources in healthcare. The need, the grading and staging, the use of the ASHA worker, greater effectiveness. Is there a family physician or a lower category of physician which can, post 3 years, begin to practice and then go back and draw the next level of graduation? Can we find ways to equip rural India with better doctors? Can we connect and convert some of these scenarios into more proactive environments? And of course, alternate medicine and the aspects on that. Besides that, there are a host of subjects. So I think, like Mr. Rao said, this is not an exact science. But I think the collective will to move forward and the acknowledgement. People often thought that healthcare was the responsibility of the doctor. Then it became the responsibility of the hospital. Now we talk about the government taking responsibility. But the fact is that corporates have stepped up, individuals have stepped up. So healthcare is a collective responsibility and an appreciation of that. I also want to acknowledge all the very powerful points which came up in the chat box. Some very enlightened thoughts on doctors, on LMPs and RMPs, on technology, on primary healthcare. And I'm sure the university will take a look at that chat box as well and incorporate it into these coordinated ideas. But I will end by saying that very often it's not where you stand, but the direction in which you're moving. And towards that, I will give credit to both the health sector individuals and the government to say that if we look back a decade ago or 2 decades ago to where we are today, health has definitely improved in multiple scenarios, yet there is more to be done, but we have many of the solutions. It's for focus and scale and funding. We can enhance the pace of improvement of our healthcare system, and the collective will to do so is definitely there. So thank you so much for this truly engaging debate and this wonderful time. Once again, our great thanks to Mr. Ajay Shankar for putting forth some powerful points and some deep research, which became the basis for this dialogue and debate. My appreciation to everyone who's been here, and thank you for this opportunity to spend an evening with you. Namaste.
Sangeeta, before Dr. Ajay Shankarji, before Dr. Sanjay Saha comes in, I'll take my undue advantage of being one of the hosts and parachute in, if you don't mind. Just a couple of comments. One, this discussion has been truly enriching and rewarding for me, even though I'm not from the sector. It opens up a whole very logical and well put forth points and arguments about how we should approach it. And I think if we were to assimilate it, Ajay Shankarji, and further to what you have done along with your other research colleague, Ms. Tiwari, I think what you have done, it will be, and it can actually form a series forward, as many of the panelists have suggested, because this is indeed a very a backbone of India's development. It's not an issue on a humanistic basis, but if we don't have good health, we will not have the development we want and the jobs we want for our people and the standard of living. Second point I wish to make is that, Sangeeta, as you know very well, the amount may be modest, but today, with the dispensation of the CSR spends from corporates, I thought I'll just touch on that point. Because as you know, health has been a major focus for spending by corporates in their own ways, whether it is in their local communities, whether it is through establishment of bigger institutions and medical institutions and so on and so forth, or simply giving medical aid in times of need. I think as the CSR funds also start to grow, I'm hopeful that even though it's a modest amount that may go into healthcare, that will also aid this big question and burning question that came up today about funding needs. The third point I want to say is on a human point. We, as you know, run a small hospital in Delhi, PSRI, the Pushpavati Singhania Research Institute, and Dr. Mahajan runs the imaging part of it. So he's familiar with that as well. I only want to say, and it is a not-for-profit hospital, it is for a surplus, so we put back the money in more and more equipments and improving things. The point I want to say is that whenever I go and see the hospital or when we talk about it, I just feel that the need in the country for healthcare is so immense, And I say this from my heart that, it's not the issue of business or government, but it's just the need. And whatever we do, I think is not going to be sufficient to really meet our human aspirations. So thank you. That's all I wanted to add. And sorry for parachuting in Ajay Shankarji on this.
Thank you. Then, Sanjay, would you like to offer?
Yeah, sure, sir. Good evening, everyone. It was indeed very enriching to be part of this insightful discussion over the last hour or so on the critical aspects of the Indian healthcare system and the way forward. But this would not have been possible without the support and contribution of some people whom I cannot thank enough. First of all, I would like to thank Vicky for arranging such a lively discussion, with special thanks to Jyoti Vij, Shilpa Sharma and her healthcare team, and Anshuman Khanna for their continued support. We are especially thankful to Dr. Sangeeta Reddy for taking time out of her busy schedule and agreeing to be part of this meeting. It is highly appreciated, ma'am. We are grateful to the eminent panel of discussions, Dr. Rao, Mr. Mitra, Dr. Mehrotra, and Dr. Mahajan, for being part of this session and sharing your views with us. A very special thanks to Mr. Harshpati Singhania, Vice Chairman and Managing Director of JK Paper, for being the driving force behind the Center for Policy Studies, JK Lakshmipat University. He has been guiding us through the center's initial journey. A big thank you to Shri Ajay Shankarji and Mr. Ashish Gupta for their support and guidance. Last but not the least, many thanks to Professor Afreen Faridi for his support in successfully organizing this roundtable discussion. We hope that this discussion forms a stepping stone for taking us to the next frontier as far as healthcare development of the country is concerned. We at the Center for Policy Studies plan to organize a similar discussion in the near future on such important topics and would love to have your participation and support. Thank you all. Stay safe and take care. Good night.
Thank you once again, everybody.
Thank you.